Hello, I'm Yana Edkin, and I'm a program director of Vascular Surgery Fellowship and Residency Program and Associate Professor of Surgery at Zucker School of Medicine at Hofstra Northwell. And today I'm going to discuss duplex ultrasound for hemodialysis access. Duplex ultrasound can be extremely useful in the evaluation of many problems facing patients on hemodialysis. It is a non-invasive technique that can show more vascular detail than physical examination. Over the last few decades, several initiatives and recommendations to guide vascular access decisions have been published. Most recently, the National Kidney Foundation has proposed the Patient First End-Stage Kidney Disease Life Plan. It is a strategy that emphasizes the right access in the right patient at the right time for the right reason. Duplex ultrasound plays an important role in HD access planning. It allows for detailed evaluation of arterial and venous anatomy before hemodialysis access is created, and may change surgical management since the identification of suitable veins would favor the placement of fistula rather than graft. In addition, there is increased likelihood of selecting the most functional vessel preoperatively, with a subsequent decrease in unsuccessful surgical explorations. Despite perioperative vascular mapping, up to 60% of AVFs still fail to mature adequately. In these patients, ultrasound can determine the potential cause of an immature fistula. After maturation is achieved, duplex examination can help assess causes of access malfunction and long-term complications such as collections, aneurysms, arm swelling, and Still syndrome. Traditionally, HD access has been surgically created by selecting most adequate arterial inflow and venous outflow. Artery vein configurations for various types of fistulas and grafts are shown here, which include radiocephalic, brachiocephalic, and brachiobasilic for fistula configurations, and forearm loop graft and upper arm straight or loop graft. In recent years, endovascular creation of arteriovenous fistulas have been developed. Currently, there are two FDA-approved devices for endovascular fistula creation in US. Wavelink, which allows to create an ulnar artery to ulnar vein or radial artery to radial vein fistulas. And the other device is Ellipsis, which allows to create radial artery to radial vein fistulas. Kidoku guidelines recommends to choose the site of HD access after careful consideration of the patient's end-stage kidney disease life plan. For patients expected to have prolonged duration on dialysis, a distal to proximal approach to fistula creation, preferentially using the superficial veins, is recommended. In patients deemed not suitable for a forearm fistula, consideration of a forearm graft before upper arm access provides the best opportunity to preserve vessels for future vascular access sites. Creation of dialysis access in the non-dominant arm first is preferred. Kidoki recommends that physical examination focused on vascular anatomy be the basis of the initial assessment and planning of vascular access creation. The guidelines suggest selective perioperative ultrasound in patients at high risk of AV access failure, such as elderly, women, patients with multiple comorbidities, those at risk of or with a history of vessel damage or central stenosis, or those in whom proper physical examination is not possible. I will proceed with discussing general principles of vascular mapping. Vessel mapping should be performed in the patient sitting upright so the arm veins are dependent to the heart. This position will optimize vein diameter along with the tourniquet use. Ambient room temperature should not be cold, and warm blankets or warm compresses can be used as necessary. Non-dominant arm should be assessed first. A high-resolution linear ultrasound transducer is used. Grayscale transverse plane imaging is used to identify vessels and evaluate their diameter and wall thickness. Color Doppler images and Doppler spectral waveforms are obtained in longitudinal plane to evaluate for stenosis or obstruction. An important aspect of planning for HD access creation is vessel size assessment. While minimum diameter thresholds for arteries and veins have not been validated, Kidoki suggests that vessels less than 2 mm in diameter might not be adequate to create a functional fistulus. The first part of vascular mapping is assessment of veins. Sequential vein compression is used to assess for compressibility, indicating patency, or loss of compressibility due to acute or chronic thrombus. Cephalic vein is assessed first for the presence of continuous vein with a diameter at least 2 millimeters. Branch points should be assessed carefully as it is common location for stenosis. Following examination of the forearm, tourniquet is moved to the axilla and the vein of the interest is followed centrally to assure that it empties into the deep venous system. Tourniquet must be removed to evaluate cephalic vein insertion into the subclavian vein. If the forearm fistula is not possible, upper arm should be assessed next. It may be possible to create forearm cephalic vein fistula even if cephalic vein in the upper arm is small or occluded. Cephalic vein in the forearm should then drain into the brachial or basilic veins via adequately sized median cubital or other brachial vein. The depth from the skin surface to the anterior wall of the vein is measured. Detection of the vein that is too deep, more than 6 millimeters, but otherwise suitable for the fistula allows the surgeon to inform the patient preoperatively about potential need for a second procedure to superficialize the vein. This discussion allows the patient to decide whether to accept the possibility of multiple surgical procedures needed to create a mature fistula. If an adequate cephalic vein is not found, basilic vein is examined in similar fashion. Arteries are examined next. Arteries should be examined for intimal thickening, calcifications, and stenosis. The presence of significant concentric calcifications should also be noted. Doppler spectral waveform of brachial and radial arteries are obtained to detect either proximal or distal obstruction. With proximal obstruction, the waveforms are monophasic and dampened with tardus parvus pattern. With distal obstruction, the waveforms have a normal triphasic pattern, but the velocity may be reduced because of diminished flow. High radial artery takeoff from brachial or axillary artery is a common anatomic variant and should be identified on duplex evaluation. Hemodialysis exosurgeons are reluctant to place forearm graft or upper arm stray graft in patients with high radial takeoff because the chances of arterial steal is increased. Assessment of central veins is another important part of vessel mapping. The subclavian and internal jugular veins are evaluated for the presence of stenotic lesions, occlusions, or thrombus. It is easiest to perform this portion of the study in the supine position to increase venous filling. Spectral waveforms should be assessed in the medial portion of the subclavian vein and the caudal portion of the IJ for respiratory physicity and transmitted cardiac pulsatility. If normal flow features are absent, monophasic flow is demonstrated, then central venous stenosis or obstruction is inferred. If the flow abnormality is unilateral, brachiocephalic vein stenosis or occlusion is likely. If bilateral, a superior vena cava stenosis or occlusion is likely. Occasionally, the brachiocephalic veins and SVC can be visualized with ultrasound. In such cases, they are best seen with a small footbridge transducer above the medial clavicle or in the sternal notch using central angulation. Figure A shows normal subclavian vein. Longitudinal duplex image demonstrates color Doppler flow signals filling the vein and normal spectral waveform with phasic temporary reversal of flow during atrial contraction. Figure B shows duplex image of left subclavian vein with abnormal monophasic venous waveforms consistent with proximal occlusion. Duplex ultrasound also plays an integral role in creating functional endo-AVF. There are specific protocols for vascular mapping for those two devices to identify patients that are candidates for endo-AVFs. First part is to evaluate venous outflow, which is upper arm cephalic or basilic veins. If patient has adequate forearm veins, endo-AVF should not be performed. Wavelength recommends using outflow veins over 2.5 mm in diameter and ellipsis recommends over 2 mm. Finding the perforator vein is a key to creating endo-AVF in both systems requires the perforator to be at least 2 mm in diameter. In addition, For ellipses, the distance between the perforator and proximal radial artery has to be less than 1.5 millimeter. Next, we have to evaluate access sites and creation sites. This is where there are major differences between the two systems. For wavelength, access and creation sites are in different locations. For arterial access, you have to access brachial artery, and for venous, you either access brachial vein or either ulnar or radial vein at the wrist. But the creation sites are either proximal ulnar artery and vein or proximal radial artery and vein. In contrast, ellipses use the same vessels for access and creation sites. You can access median and decubital vein or the perforator vein, and through the vein, you have to access the proximal radial artery. For both systems, all the access and target vessels have to be over 2 millimeters in diameter. If there's no suitable anatomy for surgical or endo-IVF creation, patients should be evaluated for graft creation by assessing inflow and outflow options, which include axillary brachial and radial arteries and axillary brachial and basilic veins. Now, I will discuss the role of duplex ultrasound in assessing HD access maturation. For the obviously mature fistulas, clinical examination by experienced nephrologist or dialysis nurse is sufficient. Kidoki recommends duplex ultrasound examination if the physical exam is equivocal. This will help evaluate for causative abnormality and assess fistula maturation progress via IVF diameter and blood flow measurements. Sonographic evaluation can address multiple anatomic features of fistulas, including the presence of stenosis, minimum vein diameter, and the maximum depth from the skin surface. Minimum ultrasound criteria have been established for fistula maturation at 4 weeks using vessel diameter of about 4 to 5 millimeters and a volume flow of 400 to 500 mils per minute. Combining venous diameter and volume flow measurements increases our ability to predict fistula adequacy. A venous diameter of 4 millimeters or greater and flow volume equivalent or exceeding 5 mils per minute confirms IV fistula maturation in 95% of cases, versus maturation rate of only 33% when neither criteria is met. A tourniquet is not used routinely for fistula examinations. A high-resolution linear ultrasound probe is used to evaluate feeding artery, anastomosis, and draining vein. Grayscale imaging in transverse plane is used to identify and evaluate vessel diameter, wall thickness, and compressibility. Color Doppler images and Doppler spectral waveforms are acquired in longitudinal plane at the feeding artery, the draining vein, and any visualized stenosis. The diameter of the draining vein is measured routinely in the caudal, mid, and cranial portions of the forearm and upper arm. The entire draining vein should be scanned and the minimum diameter should be measured. The distance from the anterior wall of the vein to the skin surface is measured. Volume flow is calculated. Size and location of branches are evaluated. Direction of flow in the artery distal to the anastomosis should be examined. Central vein waveforms are obtained, and presence of any extraluminal collections are identified. This slide summarizes normal findings of mature AVFs, which include low-resistant waveforms in feeding artery and conduit, antegrade flow direction in artery distal to the anastomosis, peak systolic velocity ranging between 100 to 200 centimeters per second throughout the axis, turbulent flow patterns, uniform axis diameter over 4 millimeters, absence of intraluminal defects, absence of aneurysmal dilatation or wall disruption, and respiratory physicity and increased pulsatility in the venous outflow system. To evaluate for presence of stenosis at the anastomosis, peak systolic velocities are measured at the anastomosis and 2 centimeters cephalad to the anastomosis in the feeding artery. A peak systolic velocity ratio is then calculated by dividing the peak systolic velocity at the anastomosis by peak systolic velocity obtained 2 centimeters cranial to the anastomosis. Peak systolic velocity ratio equal or greater than 3 corresponds to 50% stenosis at the anastomosis. Visual confirmation of stenosis at the arterial anastomosis is useful because peak systolic velocity in the draining vein may be significantly elevated merely because of acute angulation of the draining vein at the anastomosis. If the draining vein is visibly narrowed, peak systolic velocities are measured at the stenosis and 2 centimeters caudal to the stenosis. Again, peak systolic velocity ratio is calculated by dividing the peak systolic velocity at the stenosis by peak systolic velocity obtained 2 centimeters caudal to the stenosis. If the ratio is more than 2, it is classified as at least 50% stenosis. To obtain volume flow, blood flow is measured in mid-portion of the fistula in milliliters per minute, using the volume flow measurement function on the ultrasound scanner. It is important to use careful technique while measuring blood flow in the fistula, as there are many potential pitfalls in volume flow measurement. The blood flow should be measured approximately 10 centimeters from the anastomosis in the straight, non-tapering segment of the draining vein. The Doppler sample volume is adjusted to encompass the entire vessel width, not extending significantly past the wall. The velocity scale should be adjusted so the spectral waveform occupies approximately 75% of the spectral window, with the baseline adjusted to avoid aliasing. At least 3 cardiac cycles should be used to estimate the time average mean velocity. The internal diameter measurement should be placed perpendicular to the back wall of the vessel. The scanner then calculates the volume blood flow as the time average velocity multiplied by the vessel cross-sectional area. Accessory branches can divert a significant amount of blood flow from the primary draining vein, leading to fistula immaturity. Large branches should be identified in the first 10 centimeters of the fistula. Peak systolic velocity is measured before, in, and after the branch. Side branch steal is defined as high velocity flow through a side branch with a significant reduction in velocity through the main venous outflow. Peak systolic velocity in the branch that is twofold higher than the main venous outflow is a sign of side branch steal. After fistula maturation is achieved, duplex ultrasound can also be used to evaluate causes of access malfunction. Kidoku guidelines do not recommend routine duplex surveillance of fistula or grafts, but rather duplex should be done if specific abnormalities are identified, such as elevated dynamic pressures, recirculation, decreased urea reduction ratio, water hammer pulse, decrease or loss of palpable thrill, palpable masses, hand pain, or arm swelling. Infrequently, patients will have symptoms of arterial steal caused by HD access. These symptoms include hand pain and numbness, non-healing ulcerations, or digital gangrene. Asymptomatic steal is relatively common and of no clinical significance. However, severely symptomatic patients may require HD access ligation to correct the steal. Direction of blood flow in the radial artery distal to HD access is evaluated with color Doppler imaging and Doppler spectral waveforms. If the direction of flow is reversed caudal to the axis, diagnosis of arterial steal can be made. Gentle brief compression of the axis returns the abnormally reversed flow to normal, confirming the existence of steal phenomena. Photoplasmography can also be used to diagnose steal. Dampened monophasic digital waveforms that return to normal with axis compression is consistent with steal syndrome. Digital pressure measurement can also be utilized. Digital brachial index less than 0.6 obtained on the day of surgery can visibly predict which patients are at risk for development of symptomatic steal. If revision is indicated, the digital brachial index should be increased to over 0.6. Failure to accomplish this puts the patients at risk for continued steal. This concludes my discussion on role of duplex ultrasound for hemodialysis access. Thank you for listening.